Hand hygiene and aseptic technique is the foundational focus of this educational presentation. This course is designed to provide healthcare professionals with a deep understanding of how microorganisms interact with the human body and the clinical environment. We will explore the critical intersection between skin microbiology and the practical application of infection control measures. By mastering these concepts, clinicians can significantly reduce the incidence of healthcare-associated infections and improve patient safety outcomes. This introductory section sets the stage for a detailed examination of the biological and environmental factors that necessitate rigorous hand hygiene and aseptic protocols in every patient encounter. Microbiology of the skin and transmission dynamics serves as the core theme for the second lesson of this series. This section transitions from general concepts into the specific scientific principles that govern how pathogens live on our bodies and move through the healthcare setting. Understanding these dynamics is essential because it explains the why behind the protocols we follow daily. We will be looking at the anatomical barriers of the skin, the different types of bacterial flora, the complexity of biofilms, and the various modes of transmission that can lead to patient harm if not properly managed through clinical intervention. Lesson 2.1 focuses on the anatomy of the skin barrier. The stratum corneum acts as the primary physical barrier of the body, and any damage here, such as cracks or dermatitis, significantly increases the risk of infection. The acid mantle refers to the skin's naturally acidic pH, ranging from 4.5 to 5.5, which serves to inhibit the growth of many potential pathogens. Microtopography describes the ridges and hair follicles on the skin surface that can effectively hide bacteria from superficial washing. Hydration levels are critical, as moisture levels affect bacterial growth, and maceration, or overwetting, weakens the skin's protective barrier. Finally, shedding, or desquamation, is the natural process of skin peeling that removes colonized bacteria, but also generates contaminated dust in the environment. Lesson 2.2 distinguishes between resident versus transient flora. Resident flora are the permanent inhabitants of our skin, such as coagulase-negative staphylococci and corynebacterium. Their location is deep within the stratum corneum and hair follicles, making them difficult to remove. Their role is microbial antagonism, which helps prevent colonization by more dangerous pathogens, typically maintaining low virulence on intact skin. Transient flora, however, are temporary hitchhikers, like MRSA, VRE, or gram-negative bacteria, acquired through contact. Regarding removal, resident flora requires a rigorous surgical scrub to displace, whereas transient flora can be effectively removed by routine hand hygiene practices. Lesson 2.3 introduces the biofilm concept in clinical medicine. The structure of a biofilm consists of bacterial colonies protected by a thick slime layer known as a glycocalyx. This leads to high resistance, as bacteria in a biofilm can be up to 1,000 times more resistant to antibiotics than planktonic or free-floating bacteria. Biofilm formation begins immediately upon bacterial adhesion to a medical device surface. The clinical impact is significant, as biofilms are the primary cause of chronic infections in central lines and urinary catheters. Prevention is paramount, as strict asepsis during the insertion and maintenance of devices is the only effective way to prevent biofilm formation from occurring. Lesson 2.4 examines environmental reservoirs and fomites. High-touch surfaces include common items like bed rails, bedside tables, IV pumps, and light switches. Pathogen survival is a major concern, as organisms like VRE and C. difficile can survive on these surfaces for days or even months. The patient zone is defined as the area immediately surrounding the patient, which becomes colonized by their specific microbial flora. Transmission occurs when hands transfer pathogens from these fomites to portals of entry, such as touching a bed rail and then an IV site. Cleaning through regular environmental disinfection is therefore a crucial adjunct to manual hand hygiene. Lesson 2.5 details transmission modes, specifically contact transmission. Direct contact involves the physical touching of a patient's skin, blood, or body fluids. Indirect contact refers to touching contaminated instruments, needles, or dressings. Common agents spread this way include MRSA, VRE, C. difficile, scabies, and lice. Specific precautions are necessary, requiring the use of a gown and gloves upon entry to the room, with a single room preferred for the patient. Hand hygiene is critical both before and after contact. Specifically, soap and water must be used for spore formers like C. diff, as alcohol-based rubs are ineffective against spores. Lesson 2.6 covers droplet transmission. The mechanism for this mode includes coughing, sneezing, talking, or performing sectioning. Common agents spread by droplets include influenza, pertussis, mumps, and meningococcal meningitis. The range of transmission is generally limited to close contact, typically within approximately 3 to 6 feet of the source. Precautions require the use of a surgical mask and eye protection, such as goggles or a face shield, when within 6 feet of the patient. For patient placement, a single room is preferred. If rooms must be shared, maintain at least 3 feet of separation and keep the privacy curtains drawn. Lesson 2.7 addresses airborne transmission. The mechanism involves the aerosolization of tiny particles that can be inhaled deep into the lower respiratory tract. Agents that utilize this route include tuberculosis, measles, chickenpox, and disseminated herpes zoster. Precautions are strict, requiring an N95 respirator or PAPR for staff and placing the patient in an airborne infection isolation room. Engineering controls include a negative pressure room, where air flows inward and is exhausted outside or through HEPA filters. During transport, the patient must wear a surgical mask to contain the source of the infectious particles. Lesson 2.8 explores the role of asymptomatic carriers. Colonization is defined as the presence of bacteria without tissue invasion or an active immune response. The carrier state is common, such as the nasal carriage of MRSA frequently found in healthcare workers and patients. Transmission risk is high because asymptomatic carriers shed bacteria onto their skin and the surrounding environment. Surveillance through active cultures, like nasal swabs, is sometimes used in ICUs to identify these carriers. The implication is clear. You cannot rely on a patient looking sick to determine infection risk. Therefore, hygiene practices must be applied universally to all patients. Thank you for completing this lesson on microbiology and transmission dynamics. We have covered the essential components of the skin barrier, the differences between resident and transient bacteria, and the dangers of biofilms. We also reviewed how pathogens survive in the environment and the specific precautions required for contact, droplet, and airborne transmission. Finally, we discussed the importance of recognizing asymptomatic carriers. Applying these principles consistently is the most effective way to protect your patients and yourself from healthcare-associated infections. Please proceed to the next module to continue your training in aseptic technique.